Hello, everyone. My name is William Hui, and I am very excited to start this primary care ultrasound series. This lecture is for the Introduction to POCUS, Soft Tissue, and Volume Assessment. Some disclosures are that some of these cases and slides were borrowed from Global Ultrasound Institute. So we'll just start off with a few cases that can really show the value of point-of-care ultrasound at the bedside in the primary care setting. This first case is someone who comes in with a red hot swollen extremity, and the question is whether or not this is an abscess or cellulitis. Now, cellulitis, of course, it's a clinical diagnosis, but in the equivocal case and in the equivocal physical exam, this may be a little bit tougher to figure out on exam. However, once you place the probe right on the patient's skin, you see a irregular cavity that is hypo or anechoic, meaning black. There is, as the sonographer pushes on the skin surface, there is movement of contents within the center of the cavity, otherwise known as the swirl sign or a pus stultus. And this confirms a abscess. And so you treat the patient appropriately with an incision drainage rather than treating with antibiotics, and you have the right diagnosis. Another common case in primary care setting is a patient who comes in with an abdominal bulge and pain. And the question is this truly a hernia, or is there not a hernia? Again, in the very apparent cases, physical exam usually secures the diagnosis, but there are times when the bulge is so small that maybe you're not really able to tell on physical exam, or perhaps on the anatomy, it is a little bit tougher to be able to palpate this bulge. Well, by placing the probe right where the patient is experiencing this discomfort, you can see that right here, there is a bulge that comes straight out into the screen. And as the sonographer pushes on this area, it also reduces back in. And over here on the clip to the right, as the clip moves, you can see this hernia bulging out into the skin, and it is through the peritoneal line, which is this white line over here. And so on this clip here, you can see that there is a presence of a hernia on this patient. So you can easily tell whether or not these hernias are reducible and show your patient exactly that by showing them the ultrasound screen and showing them exactly what you see. And that's one of the benefits of using POCUS at the bedside. You can use your ultrasound images to show your patients exactly what you're seeing as well. Now, what about the case of someone with knee pain and whether or not they have a knee effusion? And so again, in those cases where it's a little bit harder to figure out if a patient has a fusion or not, when you place the probe right in the suprapatellar region and you see the black stripe here, here is the bright white bone of the patella, here is the bright white bone of the femur, and there's a black stripe between these two bones. This is a sure sign of a knee effusion. And this can aid in your physical exam, avoid unnecessary dry arthrocentesis, and provide your patient some comfort and show your patient the pathology that's present. What about your patient with potentially urinary retention, or the elderly gentleman with a presumed larger prostate and BPH? Well, in evaluating a patient's post-void residual, it's very easy to measure the bladder volume. And so you can very easily check the patient's PVR in the clinic, confirm an elevated bladder volume, and then help expedite the next steps in care. Also, you can even do a non-invasive evaluation of the prostate size, measure the volume, same as the bladder as well. And this can also help you start these medications like finasteride. What about cases of MSK pain, for example, shoulder pain? Well, if someone comes in with shoulder pain and you are worried about a rotator cuff tear, and you evaluate their supraspinatus tendon and muscle, this is the patient's humerus bright white bone here. Here, this band of tissue is the deltoid muscle. The middle band is the supraspinatus muscle. And if there's a black stripe completely through that tendon, then that is a full thickness rotator cuff tear, and you can help expedite this to our surgeons rather than doing a conservative approach and trialing NSAIDs and physical therapy. What about another case of someone who has abdominal pain and whether or not they have gallstones, or is this reflux? And so very easily you can look at the patient's gallbladder, see if there's any gallstones within the gallbladder. And in this clip here, the gallbladder is right here in the middle of the screen. Inside the gallbladder, usually it's black, but in this case, this grayish color that's seen in the gallbladder is the gallbladder sludge. And as you can see, this curved structure here, this is a giant gallstone that's stuck in the gallbladder neck, also casting a big shadow underneath it. These are hallmark signs of a big gallstone, and this is biliary colic. And so you can make more accurate diagnoses and help expedite a referral to general surgery for an elective cholecystectomy. And how about everyone's favorite case of the Friday afternoon with the unilateral leg swelling? Maybe not something like this, but in someone who presents with unilateral leg swelling and pain and you're worried about a DVT, how helpful would it be to be able to check and make sure if they have a DVT present or not in the proximal veins and offer some reassurance right at the bedside rather than sending the patient to the emergency department? In this case, there is a DVT present as noticed by the non-compressible vein and artery. And so with a positive scan, you could treat immediately with a positive POCUS scan and then wait for the radiology results. Rather than waiting for the radiology results. And if there's a negative bedside compression study, well, you can still get a radiology ultrasound within 1 week if there's high enough probability. So what is ultrasound, point of care ultrasound? This is not to replace radiology ultrasound. It's to answer focused clinical questions. Usually it takes only a few minutes. And it's an extension of the physical exam, and you can bill these with limited CPT codes. In primary care, why should we use point of care ultrasound? Well, first off, there is a lot of growing interest. In almost up to 3/4 of medical schools, there is currently some sort of point of care ultrasound training. And also in up to 50% of family medicine residency programs. Certainly, there's improved patient safety if you're talking about needle guidance and doing specific procedures, ultrasound-guided procedures, lower costs, reducing time to diagnosis, and you bring the clinician really back to the bedside. And so there's then improved clinician and patient experience. So all in all, this provides timely, accurate, evidence-based care to our patients. And this is actually the norm in our European colleagues, in our, general practitioners who practice primary care in the European countries. Ultrasound is widely used in these countries, and the United States is fairly behind in using this modality. To look a little bit about in the literature, there is the World Organization of National Colleges, Academies, and Academic Associations of General Practitioners and Family Physicians. and they had a position paper written on the use of POCUS in primary care. This was recently published in 2024, and they talk about how, POCUS has been introduced in a number of medical specialties, and they anticipate that POCUS will have an increasingly important place for specific indications within primary care over the coming years. This training ideally should be done during residency and CME programs, and qualified users should be able to use it and use POCUS. And of course, more research should be done on this topic. A little bit about how in the family medicine world, with POCUS in the AFP recommended curricular guidelines, this has been published more than a few years ago. And most recently, ACGME has specific family medicine program requirements indicating that residents should have experience in using POCUS in clinical care. In addition, in many medical organizations within primary care, including STFM and ACP, there are also POCUS educator and POCUS pathway courses and certificates that one can use and utilize to be able to learn more about point of care ultrasound. So the goal of today's in this primary care POCUS workshops and the training project is really to get learners to the point of a credentialed user who can perform and bill for limited POCUS studies. That's definitely the ultimate end goal. However, also just to get a introduction to POCUS and what can POCUS offer in the primary care setting, that's my goal for these sessions. In terms of the curriculum, each month there is going to be an asynchronous lecture on a scan topic recorded online and provided to you all via a YouTube link, so you can review the topic in advance of the actual workshop. And then at each month, there is going to be an in-person workshop to focus on hands-on practice. So we'll be practicing on ourselves and scanning ourselves to get some practice on how to acquire the images. The topics that we're going to be covering is these as follows. So these 6 topics will be the ones that we'll be really focusing in on today. Now, this was developed based off of experience, based off of literature that's out there, talking about the most common high yield scans that for primary care clinicians. And we'll start off with high yield scans that are easy to learn and will progressively become harder and harder, and maybe potentially less frequent in frequency. But the first few months are going to be the ones where I think has the highest utility and the highest yield for all primary care clinicians. Now, all of this is really based off of literature that's been out there. And so in 2020 in Scandinavia and other European countries, this is a systematic needs assessment looking at POCUS and scanning modalities in general practitioners and what are the most common and what are the most useful, really. And as you can see, these are some of the most common diagnostic scans listed from 1 to 30. In 2025, there was also another European Delphi study talking about a core curriculum in POCUS examinations for frontline physicians in primary care. And this involved almost 100 PCPs in nearly 30 European countries, and this consolidated a list of 40 applications, which also show a very similar list, anywhere from abdomen, gallbladder, urinary tract, to the liver, spleen, lungs, MSK, skin, pelvis, and DVT. And so we're going to really hit the highlights here with these next 6 months. And I hope you all will be very interested in learning this with me. So how do you use POCUS during the learning phase? So during this phase, you'll be performing point of care ultrasounds on willing patients, perhaps patients that already have pathology, or on patients that you're going to already order a confirmatory study. So that way you can compare your learning study with the radiology scan and see if it matches. Of course, as you do scans, you're going to be uploading into the butterfly cloud, which I'll be talking about more so later. But this will be really the area and the way in which you can keep track of your point of care ultrasound scans like a procedural log in residency. And it will be through this log that you'll be using towards credentialing. So how to get credit for a scan? You scan normals and abnormals. You can upload this study into the Butterfly cloud, filling out the patient information and worksheet. All of this will be reviewed by me within 1 week. And again, this cloud will act as a POCUS log for feedback and to get credit. So to get locally credentialed at Stanford, this has actually been added to our credentialing form in PCPH. And so the number requirement for these scans is as follows: 25 scans for all scan types, except for bladder, joint effusions, and soft tissue, which require 10 scans. Once you hit these scan numbers, then the credentialing form can be submitted to provide this privilege. Now, APP form is currently still work in process, and I'm still working on that currently. So let's talk about history and physics of point of care ultrasound, because it is very important to know about the physics portion of things before we even talk about how to do the actual scan. So with point of care ultrasound, it is kind of similar to echolocation and sound waves, as you can see in all three of these examples. The ultrasound probe acts as the sender and the receiver of sound waves. And it is with the ultrasound probe sending these sound waves out into the environment and receiving these sound signals back. That is how the ultrasound machine knows what it encounters in space, right? Depending on these reflecting sound waves returning back. And so as a ultrasound probe shoots waves out into the open, these waves can be transmitted, absorbed, reflected, refracted, and scattered all over the place. And that corresponds to the color of ultrasound. And as you may know already, ultrasound is black, white, or gray. And so if it's black, that means that the ultrasound waves are sent through things that really transmit quite well, sound waves really quite well. And that would be your gel, right? Ultrasound jelly. That would be blood or any type of liquid. And so fluid, blood, this will be anechoic or hypoechoic. Anechoic meaning without color, hypoechoic meaning less color, okay? Now, contrary, on the opposite side of things, if it is completely white, this is something that is highly reflective, highly rigid structures, similar to bones and stones. And these are hyperechoic or bright white. And then when you have something in the middle, that is isoechoic or some shade of gray. And so this image here is an image of your right upper quadrant. In the middle here is your liver, and there are scattered hepatic veins and portal veins within the liver. As you can see with these portal veins and hepatic veins, they are containing blood. And so blood shows up as black. And so this is black vasculature. The liver itself has a very homogeneous appearance. And so this is a level of gray that you will see. The diaphragm is highly reflective because it's this curved structure. So it's bright white, as you can see on this side of this screen. And then over here, this is the spine of the back. So these are the spines and these are bright white. So we have bright white diaphragm in the spines. We have isoechoic liver. We have an anechoic hepatic and portal veins. And then we also have some rib shadows. So here are these ribs and shadow that goes deep to the screen. So as you can see, ultrasound waves are waves that are outside the audible frequency, and so that explains why we can't hear these actual sound waves. And just to talk about transducers, we're really going to focus on the butterfly probe, which is actually an all-in-one probe. And so these probes are less important to know really right now. However, if you do use a cart-based machine or one of those big, higher resolution cart-based machine, well, this is a curvilinear probe. This is good for abdominal scanning because it's low frequency. So then it penetrates very deeply into the abdomen. This is an endocavitary probe, so good for transvaginal scans. This is a linear probe, and so this is good for MSK scans. This is good for soft tissue scans because of its high resolution. It's a high frequency probe. It has high resolution. So just as there's high resolution in like a HD TV, this provides the best resolution for your muscle tendons, your soft tissue. However, because of its high frequency, it doesn't really go down in depth into as much. So this really goes to a max of 6 centimeters only, whereas this one can really go upwards to like 25 centimeters or so. These other ones this is a phased array probe. It helps to sneak in between the ribs for cardiac scans. And this is more for, this is usually a rare probe, but it's a hockey stick probe used for soft tissue scans. And we do not have that here. And so this is just exactly what I was talking about in the previous slide. Now, there are a few rules of ultrasound, kind of rules of thumb, and we don't have to always abide by these rules, but it's helpful when learning to sort of keep these rules in mind. First off is the top of the viewing screen is always where the transducer is touching the patient. Okay, so when you're looking at the top, that's superficial. When you're looking at the bottom of the screen, that's deep. Okay. Rule number 2 is the orientation marker on the transducer and the viewing screen should really point towards the same direction. Now I'll go into what that really means in the next slide. So rule number 1 really basically just means when you place the probe on the skin, what's up here is skin, what's down here is deep to the body, so towards the back here. Okay, so superficial to deep. Rule number 2 is when you look at your probe, there should be a probe marker that should correspond to this probe marker on the actual ultrasound image. And so when you point the probe marker towards the patient's right, then this should be also on the patient's right. And so what that means is when you have the probe marker facing the patient's right, if you move this probe towards the right of the screen will move towards the patient's right. If you move this probe towards the left of the screen, it will move towards the patient's left. And so it matches what you're looking at on the screen itself. Versus if you have the probe marker facing the patient's head, then when you move towards the head, it's going to move that way. And when you move towards the feet, it's going to move that way. Okay, right? So making sure you know where the probe marker is very essential to knowing where you are in the ultrasound image. There's also 4 cardinal motions of the probe. As you can see, there's sliding, tilting, rotating, and rocking. And so sliding is really just translating the probe up and down, left and right. Tilting is tilting or fanning the probe on its long axis. I'm sorry, on its short axis. 3, rotating is just pivoting right on the actual area of interest. And then 4, rocking is tilting it on its long axis. The number one mistake that I see mostly in new learners of point of care ultrasound is when you're holding the probe, it's held incorrectly. I oftentimes see I oftentimes see learners hold the probe like this, kind of like an ice cream cone, but remember to make sure to hold it like a pencil and anchor, making sure you put the bottom on the last few digits and the side of your hand on the patient's body so that you can really anchor yourself and brace yourself on the part of interest. So that way, when you scan someone's hand, let's say, you don't slip right off because it's going to be a very slippery surface with ultrasound jelly. So please beware and make sure that you anchor your probe hand on the patient's body. Now, every ultrasound machine is a little different and it can get kind of intimidating when there's so many buttons, but just really know about these few buttons for now. One is the transducer button. So this allows you to choose the transducer and choose the actual scanning mode. So for the butterfly, we can review that, but basically you can change, the abdomen preset or the vascular preset or the lung preset. And so that's sort of what that button is for. Next is the gain function. So the gain, think of that as the overall brightness or overexposure in the actual screen itself. And so when you turn up the gain too much, it's going to really overexpose the image. You're not really going to be able to see the image too well. It's going to be very bright white. But when you turn it too low, it's going to be very dark, and you're not going to be able to see very much so the defining characteristics of the shades of gray, right? And so you want to make sure you have the Goldilocks, right? The appropriately gained image. And then the depth. So this determines how far the ultrasound waves should shoot into the body. And so here, as you can see on the side of the image, there's dots and then also a number. This is 16 centimeters deep. And so with the depth the depth dial, you can turn it down and turn it up. And that allows you to control how deep to scan. And so with the butterfly, you can swipe up and down and sort of swiping up and down on the actual iPhone or iPad screen, and that will actually control your depth. So that allows you to see more or less of what you want to scan. And as you swipe left or right on the Butterfly app, that's actually going to increase or decrease your gain. And that will allow you to control the brightness, okay? And so you can appropriately gain the image to make sure that you have the best image possible. The other useful tip when learning about ultrasound is something called color Doppler. Color Doppler is a very useful tool where it allows you to see the internal flow. So when you turn on color Doppler, if you see the red and blue, that just means that there is internal flow. And so it doesn't really mean veins or arteries. It just means the directionality of the flow itself. So red is towards the probe, blue is away from the probe. And we like to use the mnemonic BART. Blue is away, red is towards, to determine the directionality of flow. There's also what's called ultrasound artifacts when scanning, and these can be seen in normal or pathologic situations. Lots of artifacts out there, but we'll talk about them on a case-by-case scenario. But just to kind of talk about a few of the more common ones, there is an artifact called acoustic shadowing. What this means is in things that are highly reflective, for example, like stones in the gallbladder, as shown here and here, when there are highly reflective and rigid objects, the ultrasound waves shoots at them, reflects all the energy back to the probe, and there is nothing that's transmitted through. That means there's going to be a shadow that develops right underneath this, which is shown right here as well as here. And this is what's called acoustic shadowing. Same thing here, where when you're looking at the liver and the diaphragm, sometimes there's ribs in the way. And so when there's bright white ribs, it casts a nice dark shadow underneath it. And these are the acoustic shadowing of the ribs. There's also something else called posterior acoustic enhancement. Now, this is kind of opposite to the previous artifact, where When you scan through something that is highly transmissible and highly transmissible like bile in the gallbladder, ultrasound waves shoot through and all that energy lands on the posterior aspect of the gallbladder wall. All that energy is absorbed by that wall that it becomes enhanced artifactually, and this area is bright white. And so that's just a characteristic of ultrasounding, something that is highly transmissible, like the gallbladder filled with bile. Also, there's another artifact called the gain artifact. This is a common problem for beginners when, let's say, you're scanning something like veins, and let's say you don't adjust the gain appropriately. If you turn it too far up, you might be mistaken that there's something inside the vein. And so when you want to adjust for the gain appropriately, you want to make sure to look at specific objects that you know are black or anechoic, and then make sure that you change the gain down so that that object is truly black. For example, when you're looking at the radial artery or the common femoral vein, these things should be black. So you should adjust the gain so that the color appears black instead of white like this. And then also, lastly, there are sometimes something called a reverberation artifact. When you are scanning lungs or you're scanning, let's say, a foreign body or glass or metal, these are reflective parallel surfaces that can create a reverberation artifact, and then it can lead to these lines that kind of shoot all the way down. These are lines that is commonly seen in lung artifact, and we'll talk more about that when we do the lung topic, or just know that these can exist, and these are an artifact that you can be looking for. All right, so now we are going to be talking about skin and soft tissue. We'll be talking about cellulitis, abscess, foreign bodies, and soft tissue masses. So objectives for this is really differentiating abscess from cellulitis, identifying foreign bodies, also identifying common primary care masses, how to do a limited soft tissue POCUS, and then recognizing common pearls and pitfalls. We'll start off with a case. 24-year-old male, history of IV drug use, presents to the clinic with a warm, hot, swollen extremity. As you can see in this image, there is an irregular anechoic cavity filled with heterogeneous material inside. And as the sonographer pushes on the skin, there is movement of this pus. This is what's called swirl sign or pus ostalsis. And so this is obviously an abscess. We'll plan out the IND, look for things to avoid. These are all things that you can do with a point of care ultrasound scan. The differentiation between a cellulitis and an abscess is very easy to tell. As you can see, it is widely different between cellulitis and abscess on the left versus on the right. On the left is what's called cobblestoning, which means when there's fluid that interdigitates itself between globules of fat, and fluid, as you remember, it's black. And so this is kind of reminiscent of cobblestoning. And so this is what's called the cobblestoning appearance of cellulitis. That's not to say only cellulitis, that causes this appearance. There are also other states that can cause this cobblestoning appearance. For example, whenever there is like a swelling or fluid in the soft tissue space, for example, like venous stasis, lymphedema, these will be also indications or sort of situations where you'll see some cobblestoning. So always use your clinical exam and sort of the clinical history. But an abscess is really quite different from this cellulitis example. Now, we'll talk about, of course, clinical exam is the most important. However, it is not perfect, and as you can see, the sensitivities and specificities are also not perfect. Of course, when you look at the literature, when you use POCUS with clinical exam, it is way better than the clinical exam alone. And in a small study in the primary care literature, published in the American Journal of Medicine, N of 31, but in this small study, they talked about how the clinical exam is quite inaccurate for size estimation in up to half of patients when evaluating skin abscesses. It changed management in more than 50% of cases. It altered the decision of an IND in the primary care clinic by about a quarter and altered the technique and approach by an additional 30%. Of course, if you can see the ultrasound image and see what's there, that's definitely going to increase your physician confidence in what it is. And so it increased the physician confidence by 50%. Now we'll talk about parts and position. So these are the parts and positions that you will encounter when scanning a soft tissue. From the top, you have epidermis and dermis. You're going to see the subcutaneous tissue underneath that. Fascia always looks like a bright white line that divides the subcu tissue with the underlying, let's say, muscle. Muscle has a nice fibrillar pattern, as you can see here. And then lastly, you'll see bone. And bone usually is the brightest white structure on the screen because it is the highest, most reflective object. Sound waves don't shoot through bone. The probe and preset you want to be using, if you're using different probes, it's a linear probe with a soft tissue or MSK preset. And we'll go through some picture and pathology here. So in this example, this clip, this is showing some signs of cobblestoning. As you can see, from the top down, there is no anechoic cavity, but there are some signs of cobblestoning. And so in the right clinical context, this is cellulitis. As opposed to this example, this is a 2D image of a suspected abscess. There's very irregular borders. There's an anechoic cavity. There looks to be some echogenic material inside here. This is an abscess unless proven otherwise. A few years ago, I saw this example in clinic. This, to me, looked like an abscess. I was getting ready to prepare for an IND before thinking about sort of doing an ultrasound first. So in this example, I ended up doing an ultrasound first because it was during my ultrasound fellowship year. And lo and behold, there was no abscess underneath this lesion. And this patient actually ended up feeling much better on PO antibiotics. So this is one example of an IND that was saved. So the patient did not get an IND and did not have to go through a unnecessary procedure, which is a win. So this is one of the reasons why I do soft tissue ultrasounds in all patients that present with skin and soft tissue infections, because there are always those equivocal cases. And even in cases that seem 100% abscess by clinical exam, it may sway you when you use the ultrasound. So it doesn't really add that much more time. And I think there is some value in doing this, especially before a procedure, because you can also make sure whether or not this is, if there's any vascularity, you can check for and make sure is there anything specific to avoid prior to the actual procedure itself. In this example, this is a clear sign of a cellulitis. There is much more cobblestoning and much more fluid in this picture here. As you may know, cellulitis and abscess, it's kind of this gradient and then this continuum. And so for a cellulitis that seems to be worsening, there can be more fluid and more fluid until it becomes loculated and until it becomes an abscess. And so in that gradient, in that continuum, POCUS can be really helpful in determining, is this a drainable cavity or not? Is this amenable to an IND or not? And usually by emergency medicine standards, uh, I, we follow kind of the rule of thumb where if there is a fluid collection that's more or less more than a centimeter or so, then that could be amenable to an IND. If it's less, there's not really going to be much fluid that's going to be outputted here. And so in this example here, since there's still a lot of cobblestoning, this is not amenable for drainage. In the more acute scenario, let's say in the hospital setting, there is also necrotizing soft tissue infections to look for. And this is an appearance of necrotizing fasciitis, of air that's seen underneath and within the soft tissue. And so think of air as the enemy of ultrasound waves. And when air is seen or crepitus is palpated underneath the skin surface, um, it refracts those ultrasound waves all over the place. And so the sonographic appearance of necrotizing fasciitis are these bright white specks within soft tissue. There's a mnemonic for necrotizing fasciitis, which is STAFF, STAFF, ST meaning subcutaneous thickening, A meaning subcutaneous air, which we just talked about. And then as it advances and progresses, there's fascial fluid that dissects through the plane, which is not seen here, but the fascia will have some fluid that's dissecting through, and that is a sign of a more severe case. Here are some other things to look out for when you're scanning for soft tissue. This is a case of a superficial thrombophlebitis. As you can see, there's some echogenic clot in here. This is a superficial vein. When you press on it, it does not compress, and it is right in the superficial area. And so this is a clot, superficial thrombophlebitis. And the clinical scenario is arm pain after an IV. Here is some pathology of a superficial phlebitis that became more of a phlegmon. And so as you can see, here is the vein, the clot is inside, and then the phlegmon is actually around this area. This was seen in the emergency room, and this was treated actually with antibiotics. And also a potential incision. Here's another rare case, but something that is interesting to see. This was seen in the pediatric emergency room. This was a kiddo who had an unwitnessed injury. He had a red lump that was on the lateral side of his hip. And the story was that he was running around and hit something and developed this over the span of a few days up to a week. And the pediatric emergency fellow at that time was thinking about doing an incision and drainage based on the clinical exam, based on the warmth, based on the induration of the physical exam. However, we decided to ultrasound him first and encountered this scenario. And this, as you can see, looks like it's pulsating. The color Doppler over it shows this classic yin-yang sign. And this is what's called a pseudoaneurysm that developed after trauma. And so this is, of course, a rare case of a pseudoaneurysm, but on physical exam, there was no pulsation that was felt. However, this would have been very bad to cut into. And so another reason to use POCUS for your soft tissue evaluations. In the case of primary care, it is so common to see foreign bodies in the foot, in the hand, when someone is washing dishes and a glass plate breaks, or if there's a splinter that gets into the hand or the feet, or they're walking barefoot in, along the beach. And so this is a common scenario. And also, it is also a entity that is very much so really helpful to use point of care ultrasound to evaluate this. I have to say though, with the butterfly ultrasound probe, the resolution is a little bit limited. And so with very fine foreign bodies, it is tough to see on the butterfly, and will likely need a higher resolution machine, such as like cart-based machine. But with that being said, a foreign body looks bright white like this. All foreign bodies look the same. It's bright white, casting a big shadow underneath it. And foreign bodies, if missed, is a common cause of litigation. Some foreign bodies, like wood, are not radio opaque. And so when you're getting x-rays, they may not show up. And you're not going to order a CT or MRI on everyone. And so what else can you do? Well, an ultrasound is actually the perfect modality in between this. What's also helpful is ultrasound can help localize the foreign body and guide the removal. And so one strategy is putting two finer needles on the superior and inferior aspect of the foreign body. And then that can allow you to figure out where this foreign body is deep to the skin. And this piece of glass that was in this poor gentleman's foot was removed. Another strategy in ultrasounding patients, like let's say small digits or fingers, because it's so small and so curved, sometimes it's hard to balance the probe right on such a small area, and it's hard to scan such a curved structure. And so one strategy around that is to submerge the whole hand underwater and using the water surrounding the hand as your gel. So that allows you to send those ultrasound waves through the water bath into the area of interest. And so you don't need to use any gel with this water bath technique. You just need to balance and sort of float the probe on top of the patient's skin. And this will be what it looks like. You'll see the water that's here in between the skin of the finger and the top of the probe. And then you can see the small structures of the skin quite nicely. There's something called the near artifact, near field artifact, which means that when you're scanning something that's so close to the probe, for example, if you place the probe right on the skin surface and the finger is so tiny and the foreign body is just right on the surface, so you can't really, it's hard to really tell where it is. The near field artifact shows up as a way of not being able to tell or not being able to visualize things that are too close to the probe itself. And so you might think that there's actually nothing there when in fact there is. And so one way around that is to make sure you have enough distance between the actual probe and that area of interest. So as you can see, there is much more distance here. And so now you'll be able to scan and look at the superficial tissues much more clear than like this. This is just a slide to show how a foreign body will look underneath the skin surface and how, for example, with glass and metal, how there will be a reverberation artifact that can be seen deep to the actual foreign body. All the things that POCUS is good for versus X-ray. And so from fishbone, spines, thorns, plastic, wood, and glass, these are things that POCUS can really, be used to be able to visualize rather than using X-ray. The other thing to note is the indication of someone who comes in with a neck lump, and you're wondering, is this neck lump connected to the thyroid or is it not? Does it look like a lymph node, or is it some sort of atypical mass that should require further evaluation? I think POCUS can be really helpful in these scenarios. And also, this is also a great tool when learning where the thyroid is and teaching your medical student, hey, when you're palpating the thyroid, it's actually a lot lower. And you can show them exactly where it is by way of using the ultrasound probe. So looking at the area and evaluating let's say the neck mass, you see something like this. And this is your typical lymph node. A average typical lymph node is oval in shape. It has an echogenic hilum. So this is how it usually looks. So echogenic meaning white, and it's oval in shape. usually less than 1 centimeter, right? And usually the color Doppler will show internal central flow. If it is more of a atypical lymph node or a reactive lymph node, the lymph node will look more regular, or I'm sorry, more round in characteristic. The vascularity of the blood flow will potentially be more hypervascular, so there will be more blood flow, and it might be even more peripheral. I would strongly recommend not using this as a way to tell between a lymph node that requires IND or FNA versus not. I still think a time duration approach is still the best approach. So making sure that lymph nodes reduce in size and sort of go away within a month. And if not, I think you should still get radiology imaging. However, the time when I think this is the most useful and most helpful is this related to the thyroid or not? You can easily tell whether or not this mass is connected to the thyroid or not, right? Is it a lymph node? Is it another mass, or let's say a cyst or a lipoma that's just off to the side? Um, and yes. Here is another pathology. This is a lipoma, and this is what a lipoma would look underneath the skin surface. Lipomas usually have a pattern that looks like the surrounding fat. And so if you didn't know this was a lipoma initially, just looking at it, um, that's fairly normal because it can really quite blend into the surrounding tissues, which is fat, right? One of the hallmark signs is, well, it's a rubbery appearance. So using your physical exam, right, of course, but also when you're scanning through it, it should have these linear reflectors, hyperechoic reflectors through the lipoma. And it should be fairly well circumscribed. And so this bright white line surrounding this very superficial lipoma is the uh, is the the lipoma's structure that we can see here. This is another appearance of a lipoma that's surrounded by this bright white area. And this is, a little bit, it looks a little different than the one before. However, it's also still isoechoic, and it is surrounded by this white appearance of this sort of sac or the lipoma wall. Here is a epidermoid cyst. This is a epidermoid cyst because it has a nice cystic appearance. Cysts usually look black, and so it's well circumscribed. Sometimes it can have some echogenic material inside. And the hallmark of an epidermoid cyst is this central punctum. This punctum attaches to the epidermis. And so if you can see it on exam, or if you can only see it sonographically, this can be an indication that this is an epidermoid cyst. Now, occasionally, there might not be a punctum present. You might only just see a cystic appearance underneath the skin and some echogenic material. However, if it is not irritated or inflamed, you can usually tell the difference between this and an abscess by the way it looks. This usually has a more of a well-circumscribed appearance versus an abscess has a more atypical, irregular appearance. And then here are examples of ganglion cysts. So ganglion cysts are very common, right? Seen in the wrist, seen in many different places, seen in the hand. And ganglion cysts usually are bright, I'm sorry, all dark, simple walled. So there's nothing else that's inside this ganglion cyst. And this is just the way that you would see a cyst appear under ultrasound. In terms of the protocol for scanning soft tissue, the way to do soft tissue scanning is by using a probe cover to protect the probe when scanning infected skin. So always make sure to protect the probe if you are scanning, like let's say a cellulitis or an abscess. So that way you're not, you know, bringing infected material from one side, from one patient to another. Then you want to start at normal tissue, scan into abnormal tissue, and then always scan in two planes. So when you're doing a clip in the short axis, then also do a clip in the long axis. Because in radiology, they always say one view is no view. So always make sure to look at pathology in two views and always make sure to check for color Doppler for flow. In pediatric patients, if they're worried about pain or you don't, and in discomfort and you don't want to push too hard with the probe, you can also use other ways of scanning a place where it really hurts. You can use an IV bag with gel on top of the IV bag and on the bottom of the IV bag, and that way you can scan through the bag into the area of interest. Or, for example, a water-filled glove. And again, a water bath to look at foreign bodies. So for example, in this image here, this is the foreign body that's seen in the soft tissue. So remember, some pearls and pitfalls. One is to always use color Doppler to look for vessels. And two, make sure to optimize the image using the depth and the gain appropriately. Here are the works cited and the resources that I've used to create this presentation. Okay, so lastly, we're going to be talking about volume assessment, JVD and IVC. Objectives is how to use the IVC or the JVD as a supplement to your volume assessment. Now, this is particularly useful in the inpatient setting, but I can still see some use case scenarios in the outpatient setting. For example, when you're seeing someone who's coming in after a ED or hospitalization for heart failure, or in someone with long-standing ESRD and you're worried that they're fluid overloaded. So with JVD, this is a clinical exam. However, there are many cases where you can't see due to anatomy or whatnot, and it may not always be very easy. You can use POCUS to your advantage to doing a more comprehensive volume assessment, more than just your physical exam, by looking at your JVD, by looking at the IVC as a correlate for volume responsiveness, by looking at lung ultrasound, and by checking for pleural effusion. To visualize the JVD, it is actually really quite simple. You place the probe very lightly, horizontally, like so, on the patient's neck, right above their clavicle. Some tips for doing so is first, make sure that you're on the vascular preset and try not to push too hard or place too much pressure, because even light pressure can collapse this internal jugular vein. And make sure your patient's not talking. There's a really great video on the Stanford 25 using ultrasound to examine neck veins that I will include for you all to review. So how would you utilize this in the clinic setting? One way that I choose to do so is I don't go out and measure the JVD in every single patient because I think that's too time intensive and I don't think that's going to be very valuable in our primary care setting. I usually will do a quick sort of qualitative assessment in someone who I think is volume overloaded. If I think a patient's volume overloaded, first I have the patient sit upright at 90 degrees. I place the probe right at their neck, looking at their IJ. And if the IJ does not collapse throughout the respiratory cycle, so as the patient breathes in and out, and it doesn't collapse like so, but it stays big, like your artery, right? This is actually 95% specific that the JVP or the JVD is more than 10 millimeters of mercury or higher. And it is based off of this study, okay? And so this is a great screening method of, okay, I have 5 seconds. I want to supplement my physical exam really quickly. Or is the IJ collapsing here? Usually in the normal patient, the IJ collapses, and as they breathe in and out, the IJ collapses in this position. How do we obtain an IVC scan? Okay, so with IVC, basically it is a scan to take a look at the inferior vena cava and looking at it and looking to see whether or not a patient is volume responsive. And so the internal vena cava is found in the xiphoid process. You place the probe horizontally, okay, and you will see this appear on your abdominal scan. Okay, so when you place the probe horizontally, you'll have on the left the abdominal aorta, on the right you have the IVC, and over here you have the spine. And so it almost looks like a frowny face. And when I talk to new learners about with POCUS, I always look at this, tell them to look for the frowny face. The left eye is always open because it's your aorta. It's the muscular aorta. It's pumping blood. It's the aorta, so it has the muscular walls. The vein can be collapsing as the patient breathes in and out. A normal vein kind of looks like this, where it's like half collapsed. And then the bright white curved structure is the spine. So when you find the IVC, this is how the IVC looks. And you can look at it in horizontal axis, which is like this, or in the longitudinal axis, like this, as you turn the probe 90 degrees towards the patient's head, like so. And when you have the probe in the longitudinal axis, you can see the hepatic veins draining into this IVC, and it goes into the right atrium. And so you can see the IVC in its long axis again, and in the short axis, such as in the beginning here. So just to review, this is what we're looking at, the right atrium, the IVC going into the right atrium, if we're looking at it in the long axis. Now with the IVC in its long axis, you'll see this here and the hepatic veins draining in. This is the hepatic vein draining in into the IVC. Now with IVC, usually I like to use a sports analogy because the IVC, as you know, it's a correlate for right atrial pressures. And so it's only really helpful when it's really big or really high or really low. When it's really low, patients likely volume deplete and they're more volume responsive. So the picture to the left. Whereas when someone has higher right atrial pressures, they might be they're likely less volume responsive. And so their IVC is big and not as responsive. And they look like this. Okay, so with the sports analogy, the low IVC, I think of it as a frisbee because it's very small. It collapses with each breath. It can almost even touch. There's more than 50% collapse with each breath. Versus something like a basketball. It looks just like the aorta. As you breathe, it doesn't really change very much. Less than 50% collapse. And then somewhere in the middle is a football. So frisbee, football, basketball. Frisbee, football, basketball. Just like so. By grouping these IVCs into these three categories, then you will know and you can very easily estimate right atrial pressures. A frisbee, low right atrial pressures. This is someone who is likely more volume responsive, so someone who might be able to tolerate some fluids, versus someone with very high right atrial pressures and less than 50% collapse of the walls. This is someone that's less volume responsive or less volume tolerant. And then somewhere in the middle is somewhere in the middle. Okay, so now that we're done with these few topics, I recommend that in the next month, I hope you can utilize POCUS in your day-to-day to scan your patients with any soft tissue concern, and also in your patients with a need for volume assessments. And then in the patients that you do uh, obtain a radiology scan, compare your own POCUS results to that report. We will do the in-person workshop very shortly, but thank you in advance in taking a look at this video beforehand, and we'll see you in the next one.